consciousness just by the things that we're asking him, okay? So that's a big thing to remember. Don't get caught up in alert, conscious. Ask them pertinent questions that they can, okay? Simple math problem they got to think about. If they're unresponsive, hey, we're going to move into that. Next slide, please. Continue with our primary assessment. The big thing is that mechanism of injury, figuring out what caused the injury, how it caused, what's it going to affect. Is there any potential to threat of life? Next, please. So we're going to do a sample. The big thing is the most common symptom of musculoskeletal injury is pain, right? Localized pain. So you're going to ask that person, okay, where does it hurt? And it's going to be, okay, it hurts right here. So for me, I'm not going to go right to that humerus area, okay? I'm not going to go right to the humerus area. I'm going to start down below, okay? How's this? How's this? How's this? And then as I get to here, then I'm going to start to palpate gently, and then I'm going to go all the way up past it, okay? And then I'm going to look at that other arm, okay? How's that compare? So if I'm getting some pain that's being elicited through my palpation, okay? Now, when I stop here, what do I feel for? What am I feeling for?
Brachial pulse.
Brachial.
What's that?
Brachial.
So there's a terminology.
Crepitus.
Crepitus. Okay, you guys know what crepitus feels like or sounds like?
Bubble wrap.
You know, squeeze a box of cereal.
Rice Krispies.
Okay, Rice Krispies cereal, when you have that kind of crunchy grinding noise. Okay, sometimes you can feel crepitus underneath the skin for that. You might feel some jagged things, something sharp sticking out, you know, bone fragment. Okay, you might be able to see or feel the deformity. Okay, you want to note that area. All right, assess distally. All right, so if I'm working with a humerus fracture, okay, can you wiggle your fingers? Can you grip my finger? You know, what kind of grip strength do they have? Does that elicit any kind of pain? Are they able to move their forearm, their wrist? Is there any pain with that? Okay, and then on a scale of 1 to 10, 10 being the worst. Okay, just remember, it's their scale of 1 to 10. Okay, if you can withstand somebody dropping 50 pounds on your toe and it doesn't bother you, okay, your scale of 1 to 10 is different than somebody else's. So just remember, it's not how you feel about pain, it's about how they feel about pain. Because a lot of times you'll say, on a scale of 1 to 10, 10 being the most, how does that feel? They'll say, oh, that's a 9, and you'll go in your mind, bullshit. So again, say these things in your head, not out loud. All right, next, please. So deformity is a common finding, okay? Mild is usually where you see swelling. Swelling is caused by bleeding, okay? So just remember that. You might see initially some bruising on the initial. Usually it's bruising doesn't start until a little bit later in the maybe by the time you get them off the hill and down to far, you might start to see some discolorations. Obvious gross deformity, you're gonna go, okay, this could either be a dislocated ankle or you could have a fractured tib fib at the joint, above the joint. Next, please. So just like anything else, if it hurts, you try and protect it. Don't touch me there, stay away from me. They're gonna want to splint it. So be gentle, be supportive, be empathetic, and it's one of those, don't give me that, you know, be gentle as you're reaching towards them. And just remember that first initial reach towards them, they're going to have that, pull away effect from you. So this is called guarding. Next, please. DCAB, BTLS. You guys know that acronym?
Yes.
Remember,
Yeah.
going forward, remember these acronyms because they're going to be on a test. They're always on the test. And then after you've assessed the primary chief complaint, make sure that you do a complete head to toe. Okay. And for me, and I get yelled at a lot on the Hill for doing this, but it's just how I was raised, by wolves in the valley. Is I usually stand over somebody, and I start from the head and feel the head, and I'll come down, feel the back of the neck. I'll come down over the shoulders, okay, down their arms, down there, then I'll come up to the armpits. And like I said, this is where you can get into when you're examining a woman. You come into the armpits, you stay outside, and you come in, feel the rib cage, right? Breathe in, breathe out. That way I feel if I got, then I can reach around the back, feel the spine, and then I go down each leg individually and feel that way. So a lot of, up on the Hill, a lot of people do it on the side of the patient. Like I said, it's just a bad habit I have that I've always done a head to toe trauma assessment, doing a head to toe, but when I'm standing over somebody. And for me, it's because I'm looking right at them when I'm doing it. So I've got that eye contact, and just avoid focusing on the obvious injury. Like I said, this skier here could have planted, right? And I'm focusing in on, he's saying he's got a pain in his right leg, and he could have a compression fracture in his back. Okay, so don't get tunnel vision. Next, please. Any major bleeding, we want to control that immediately. Next. And remember, when you're dealing with kids, they're going to be scared. So if you have a parent there with them, and again, like I said, you don't want to embarrass them if they're with friends, right? So you don't want to embarrass them and make them look like they're being immature about their injury. The suck it up, you're okay. So be empathetic and guard against trying embarrassing them in front of their friends while you're examining them. They're in pain. Accept that they're in pain and that their pain is real. You want to expose when you can. Sometimes this is gonna be hard on the Hill, but once you get them down and far, okay, this is where the scissors come out, guys. Patty will tell you you can find a lot of joy in cutting off somebody's expensive pants, ski jacket. On the fire department, the holy grail was to cut a pair of $600 motorcycle boots off of a cop.
Yep.
So come close. I never got it, but so when you're in far, that's the time that, hey, we want to start stripping them down. Again, do your diligence to be to protect people's privacies. Limit the amount of people that are in the examining area. If you need to cut something away to expose, make sure you've got a blanket to put to cover up what you've had to expose. Okay. Next, please. We've already talked about this. Again, the Hill On the hill, it's quick. Stabilize, transport that's what our main focus is up on the hill. Okay. Correct life-threatening when we need to. Okay, as it presents itself. Splint, package, transport. Okay, we're not looking to take a complete set of vitals up on the hill, right? If I want to get a pulse on somebody, okay, what does taking someone's radial pulse tell me? Anybody?
Their blood pressure is at least, 80, I think?
Great. So now I've got a pulse, the quality of his pulse, right? If it's fast or if it's slow, right? If it's weak or if it's bounding. But if I have a radial pulse, I got a blood pressure, right? If they're talking to me, I've got an airway. If they're making sense, I've got a level of consciousness. I don't need a blood pressure cuff, a stethoscope. I don't need an EKG. I don't need a lot of tools other than being able to take someone's pulse and ask them questions, right? Okay, so that's something you guys need to learn and understand and embrace. Taking vitals is for down and far, okay? Understanding what I have up on the hill is I can get that all through a good patient assessment, asking pertinent questions, and being able to locate a pulse, understanding what a good respiratory inhalation looks like, and being able to take in that information and make decisions based on that. Okay. So next, please. So we talked about this before. You always want to check the distal status of your injury. So you want to check for a pulse, cap refill, right? Fingers and toes. Can you move your fingers and toes? And do you have a sense of touch? Can you feel me, running my finger, or using a pen is a great thing too, okay? If it involves the spine, always assess all of the limbs, okay? So, hey, grab my hands, okay? Can you squeeze my hands? Great. Hey, can you hold your hands up? Phenomenal. Can you, press down on the gas, pull up with your feet and heels? Can you feel all that? Great. And then you want to make sure you document, you check for all that. Next, please. So we've done our patient assessment, right? We know what our mechanism is in injury. So start formulating a plan, okay? What are we going to do? What do we need to do to manage the injured parts? Are we going to need a toboggan? Are we going to need ground transport? Is there any special considerations I need as far as the splinting? Is there something unique that I'm going to need? Do I have the proper splinting materials with me? Do I need to relay to dispatch that we're going to need pain management for this? Okay. So we have that femur splint that's very easy, compact to use, and to learn how to put that on. It doesn't take more than one person to do it. We have the long splints that are packed in a toboggan, and basically all it is about a 3-foot piece of plywood that has got some foam padding on both sides, and it's got a canvas, I believe.
Funny, we did change those out.
Oh, you did?
Yeah, we've got the quick splints. They're the ones. They're kind of like the Apaco pad, like a vinyl material with foam in the inside, and then
Okay.
straps going around the top, kind of like an aluminum material inside to give you rigidity. And those are, we got rid of the plywood ones.
Okay, so I'll be doing some learning when I get up on the hill this year, it looks like. So again, what sucks is we don't have those things, or I don't have those things to show you, to put your hands on and practice using them. So when we get up onto the hill, when we're allowed to get up there, that's what I'm going to be encouraging everybody to do. If we can go to the next slide, Patty.
Tony, why don't we take like a 10-minute break?
Okay.
Okay, it's 7:30, I think 7:32, so 7:42 come back.
Yes, ma'am.
Perfect.
Mike, did you say those splints were made out of metal or aluminum?
So there's a video in the chat. See, right above the, let me look for it here real quick.
Okay, yeah,
You guys did your sign in around 7:02 p.m.
Okay.
Or if you search quick splint for leg injuries.
On the injured joint. Okay. But how are we going to treat this? Hello? How are we going to treat this?
Splint and go.
Stabilize.
There you go. Treat it like a fracture, splint it, help them support their weight, transport them, and then they can decide whether they want to go by private or they can get somebody to take them down the hill. Next. Same thing. You might see some bruising over the muscle area, but for the most part, there's not a whole lot that we can do. Be supportive, assist them to where they need to go. When I think of strains, I mostly think of backs. So, somebody lifting, hurt their back. You might see a torn pectoral muscle or something like that. But again, there's not a whole lot that we can do with the strain. Next, please.
Hey, Tony.
Yes.
So just to kind of, you were mentioning like help them out with like what we can do as far as like splinting. The other thing we're gonna, on our new incident form is disposition, the line for disposition. So we're gonna give them an advised disposition, like, hey, you need to see, and pretty much the only thing we're gonna tell them is you need to see a doctor always. We're gonna give them a time frame. We think it's something that's urgent. You're gonna be like within the next 2 hours, less than 2 hours, 2 to 4 hours, 4 to 8, 12 hours, whatever. If they're not from Vegas and they're traveling home and it's a musculoskeletal, seeing a doctor in Vegas isn't going to buy them anything. They can go home and see a doctor, but you still want to advise them to see a doctor.
Yeah.
And then right below that is their intended disposition. And we're just trying to get like a line from them saying, yeah, I do plan on seeing a doctor about this. Then they sign the form with that statement. So now we have a little bit to go back on. Oh, they told us we're going to go see a doctor. So just wanted to add that in there.
Yeah, always, when we're in FAR, before we release them, it's if we feel that they need to be transported, we're going to encourage them that we have AMRs on the way, AMRs here, Medic West is here, whatever. We advise that you get transported. If you're not going to get transported to the hospital, then we advise that you have a friend take you there. We deal a lot with Centennial Hospital because it's the closest, it's the first hospital on the way down. There's also the UMC Quick Care and a urgent care. There's UMC Quick Care on Centennial over there by where like the Trader Joe's shopping area is. And then there's an urgent care over by the Smiths on Durango. So we usually try and point them in that direction and encourage them. If you're not going to go right away, then these are the things that you need to make sure that you follow up on it. And we do, you want to do a CYA. And the disposition is a great idea, that especially if it's documented, that's going to help us. So signs and symptoms of fractures, again, they all kind of mimic one another. That's why I say treat everything like a fracture. Pain at the fracture site that worsens upon movement, tenderness, palpation, swelling due to the bleeding at the fracture site. You may or may not see bruising, decreased motion because of the pain, lack of bone continuity. It doesn't look right. Tenting on the skin because you've got that fracture, that movement. And then we talked about bone crepitus, the noise and the palpable feeling of crackling when the fractured bones rub together, that Rice Krispies cereal frill. Dislocations, again, pain, swelling, deformity, reduced joint motion, unable to move. So if their shoulder's in a spot and they can't move it, their knee, their elbow, something like that. You get numbing and tingling distal to the injury. So I had talked about this in the beginning, about the clavicle is located in the upper portion of the anterior chest wall. It's a bone it's easily broken. When somebody does break that collarbone, you get that their shoulder kind of drops and they get this unlevel look. It's like when they're like downhill. And it's one of the worst fractures to get, not so much as the pain, but there's just no way to freaking splint it. There's no way to comfort it. And then what you have to worry about is that fractured clavicle doing damage to the AC joint there in the acromial process. So.
And of course, a lung collapsing.
Yeah, and if you can go back, Patty, to the collarbone. So if in your anatomy, what runs along that clavicle?
There's an artery there.
Yes, there's the subclavian. You've got vascular system that runs along that collarbone. So breaking that collarbone does put at risk of somebody having some major bleeding. Okay, so that's something that you have to account for. Okay, so next slide. Again, like I had said, it's most fractured bone. This guy's got a whole lot of happiness going on right here. It's quite, like I said, they go right into that guarding. If you see it a lot in football, especially if you're a Cowboys fan and you watch Tony Romo play, he had a habit of breaking his quite a lot. But they as soon as it happens, they clutch their arm, they clutch their shoulder, and they're like just holding all of this right here, not wanting to move it, and they're moving to get off the field or go somewhere. And again, self-splinting. So next.
And the clavicle fracture, yeah, so it also is like a direct blow to the shoulders if they maybe fell off a jump directly on the side of their shoulder where it would push that clavicle into the center of your neck. If you'd picture that.
Yeah, and this one shows that tenting over the area and the bone. You see that bone sticking up. And again, when you'll be able to palpate this. So when you're doing that, make sure you're palpating both sides and you're going to feel it. Next, please.
In the clavicle, I've fractured mine. And it's like 7 pounds of force will do it. And it's not fun.
So just going back over that. So because of the AC separation in there, sometimes you can think that there's a shoulder fracture. when it's more or less just the clavicle pushing against that joint and separating it. So a lot of with the AC separations is the outstretched arm. You land with that force and it pushes this all up and forces everything up. That's how I separated mine. Was I was laying out mountain biking and took a spill that way. So next. We already went through all of this, but the point presentation over the AC joint. So just the mechanism of injury is what you want to concentrate on. The skier who falls forward, the biker does a scorpion over the handlebars, landing on that outstretched arm and shoulder. So just the shoulder dislocations, usually anterior, with the ball comes out in the front. Like I said, you'll get people that it happens quite often, and they're able to just by twisting their arm a certain way or pulling down and twisting can usually pop it back into place. Because of the stretching that happens, it gets loose in there. And basically when they go in and do a shoulder surgery, one of the things they do is they go in there and they just throw some sutures in there and tighten all that space back up. Next, please. Man. This can present with some difficulties in trying to, usually you can get it done by just putting a sling in a swath, right? Bringing it close to the body. In the position that they're guarding it in, but sometimes it'll get locked out. And again, this is where you got to get creative, where you're going to have to build a splint in this area here, right? So we've got the SAM splints. It's a bendable aluminum with some padding on it. So you might need to make a splint that fills this area here, or using some towels or a pillow or such, filling a space here that they can support their arm this way. And then, trying to get them in a toboggan is going to be somewhat difficult. So sometimes you got to get creative.
I had a quick question regarding
Sure.
that. So I know we were talking about CMS. If the CMS is compromised, do we still don't try to realign the arm in any way, or just go to transport?
I'm gonna attempt some, but it's all gonna be gauged on pain.
Yeah.
Pain and resistance. I mean, it's kind of like when you're trying to put something together. I'm trying to force tab B in the slot A, and if I'm really having to force it, then I'm going to get to a point where I'm going to break it.
I
Okay.
think, Tony, too, like there are some techniques that we can employ that would offer a passive way of maybe getting that shoulder to reduce. If it makes them more comfortable, if you just have them lie down with their shoulder hanging off of the side of a bed, it might just actually relax enough to drop in, if that provides any comfort too. There's techniques that we're going to work towards to actually start reducing shoulders. There's going to be a process we need to go through to get that approved, but we can teach a little bit of these things to like make somebody comfortable in the meantime if we're going to get an ambulance there, and it might actually reduce for us. It's about the limit to where we would be able to provide some of that comfort, as opposed to like manipulation of the joint.
Yeah, and like I said, it's it can be a very nerve-wracking thing when you pop somebody's shoulder back into place. Or I've done a patella, and Patty will know who I'm talking about. It was Matt Netsky. It made me pop someone's knee back into place, and I still have that freaking nightmare in my head. So next, please. I'm not gonna, I think everybody comfortable with shoulder dislocations in the clavicle?
So we'll go here. Scapula.
Yeah.
Humor. This is nice.
All right, here you go. All right, so the humeral head and neck fractures at the top of the humerus, the ball can be broken. So you see, hands out, coming down, all that force going up in the shoulder, you get that neck injury or just below it. Deformity, you don't really see the deformity because it's the ball, and the ball is inside the shoulder joint, right? In the socket there, so you're not going to see that. What you are going to have is a lot of pain, a lack of movement. So next, humerus shaft fractures. Okay, those are more common. Again, with all of this stuff, it's going to go back to point tenderness, swelling. Is there an angulation? Is it a deviation from being straight? Between the shoulder and the elbow suggests a presence of midshaft fracture, but it can be anywhere up the length of the bone, right? It can be very unstable because that's the big meaty part of your arm, right? It's a larger bone, so it takes up a good part of the structure. That breaks. Now you got this big, you got the fulcrum of the rest of the weight of your arm hanging on it. So you can get some bone through the skin on those. The nerve spirals around the middle and the back of the humerus, so you want to make sure that we're checking distally for CMS. So the elbow, you have 3 bones that come together at that joint. The radius and the ulna, and they connect in there to the humerus. Gross deformity of the elbow sticking out. That one might be, to me, more successful when you were talking about, hey, do we try and put that one back in? Again, I would love to get that class, Mike, on how you do those, because to me, that one would be scary. Shoulder, I could see the shoulder because it's a ball and socket, but man, that elbow, you got 3 bones going in there. I'd like to see how they do that one. So. Because of your elbow is actually supposedly the most sensitive part on your body is your elbow, is because the nerves run so close over the joint of that area. So it makes it, when you hit your funny bone, it's not the bone, it's the nerve that you hit. So you have a lot of veins, nerves that are proximal to this area. So they all can be damaged and threaten the viability of that extremity when you have the elbow. Next. Again, same thing with distal humeral fractures. It's more of the same. Next. I think it just goes without saying. Usually, if you fracture your elbow, it's going to have a hard time, extending it or flexing it. So next. And again, with all of these, we're going to splint them in a position of comfort, right? Understand the mechanism injury of how this person's complaining of pain in his shoulder, his elbow, his humerus, or whatever. So we're going to look at the mechanisms injuries. and go from there.
Just one thing to reiterate though is, you know, the process for splinting would be for over a joint, right? We want to go long bone to long bone. And then for over a long bone, you need to go joint to joint to make sure you get a good splint there. You can't splint that humerus just by wrapping a little bit of putting your SAM splint right here in the middle of the humerus. It's got to connect this to the shoulder in order to immobilize that whole bone, right? So.
The good x-ray of a dislocation. And like he was saying before, I mean, this looks like it would be pretty simple if you just, you know, put a little pressure underneath the armpit, grab them by the wrist and pull down, maybe a little twist, and it should go back into place. But again, you've got nerves and veins and arteries, you know, running all through that area. And that was, like I said, that was one of the big things that was pushed into our heads when we were going through paramedic school, is why we don't want to quickly try and pop a joint back into place without x-ray, is not knowing where those processes are. So next.
What?
Like I said, I'm if you guys don't mind, I'm not going to spend a whole lot of time on these specifics.
There's more of a child abuse kind of thing. This is that grabbing the kid by the hand.
Yeah. Next. Ooh. Forearm. So we talked about this, the radial and ulna injuries, wrist fractures, common among snowboarders because of the way they fall. So always, like I said, I'm keep repeating it, going back to mechanisms of injury. And then like Mike was saying before too, and we go to splint this. So this is going to take some being creative, where you're going to want to support the wrist and the palm. So you're going to build up underneath his hand, and then you're going to build up underneath the fractured area, and then you're going to put your splint in there to support it. You're going to run that up past his elbow, probably about halfway up his humerus. And that way the bone is supported from the tip of the finger up past the break to the elbow. Does that make sense?
Yeah.
Yes.
So, okay, next.
You see
So,
this? Yeah.
Hey, Tony, just that last slide. You know, we see a lot of these angulated fractures of the wrist, like that one, Patty one forward. Sometimes you'll get that point tenderness. They're going to point to the wrist, and you're looking at it, and it just doesn't look broken. You're like, I don't see what you're talking about. You must have sprained it. No biggie. That Colley's flat fracture or the silver fork, that's going to present as if there's a sprain of the wrist, but it's actually a broken distal radius or ulna, and you won't really be able to see the break in the end of that process there, but it's broken. So if that's just a point tenderness right at the end of their wrist, it doesn't look broken though, but you can push on it and it really makes them increase in pain. Suspect a fracture and advise them that it could be fractured. Like you were saying earlier, always treat it as a fracture. We don't have X-rays.
Yeah, and if I sound like a broken record, it's every one of these slides is going to be the same thing. Deformity, pain, swelling, they're all, whether it's a sprain or a fracture, they're going to mimic one another to a certain degree. And unless you've got Superman standing next to you with x-ray vision, you're not going to know what it is. So just treat everything that take for granted that it's a fracture. Prepare for the worst, treat for the worst, and the best news is, you know what? Hey, it wasn't broken. Next, please. So the scaphoid fracture, I believe you get, same way with the falling forward, you're catching that thumb coming back. I believe too, you see that a lot of this with skiers with the poles, especially if they're using their straps, and then now they got their strap attached to their hand, and then it's on the pole. They plant it, it gets stuck. They go forward, and the pole stays in place. So you'll see a lot of that. The same thing, you can have that break, not of just the thumb, but that scaphoid process down there, and it's one of those. It's in an area that you might not see a deformity, but you're going to see, you're going to get some obvious pain and swelling there. So, like I just said, the skier's thumb, when you catch that pole, and we're gonna do the same thing when we go to splint it. With this, you're gonna, I usually like to put a little bit of Curlex in the palm to catch, to give them something to rest on, and then I'm gonna splint from the fingertips and then to the mid forearm for a wrist fracture. And that's what's nice about the SAM splints, is they're nice and rigid, so they provide a lot of support. But there's, I always fall back on an old cardboard splint. They have their purpose. So just remember, any bone of the hand may be fractured or dislocated, especially the fingers and thumbs. Again, just being able to assess the sensation and motor functions. Make sure, see if they can make a fist, flex their fingers, fingertips. Can you do that? Raise your, turn your hands, make a fist, wiggle your fingers, spread them apart, bring them together. Just things that you're going to use to assess, not just for hand fractures, but anything on the upper extremities. Same way with the toes, when you get them down into far, and if you want to need to, if you've taken the boot off, and how you want to assess the foot and the toes.
Amputation.
So amputations. What's our main concern with an amputation?
Keep
Bleeding.
the parts together.
Bleeding. Okay. So what's the normal function of the body? How does it protect itself with an amputation? What's the first thing it's going to do?
Shunt.
Coagulate and
It's going to shunt. Okay. Your veins are going to constrict. It naturally, everything wants to protect the core, the core and the head. Okay. So anything externally is going to shunt. It's going to shut down. It's going to try and constrict. Okay. So then after that, we need direct pressure. Okay. So we may want to put on if the bleeding's significant enough,
Tourniquet.
a tourniquet. Okay. And what do we want to try before the tourniquet?
Direct
Direct
pressure.
pressure. So just with a finger, just grabbing some 4x4 and some gauze, putting a direct pressure over there, trying to get that bandage down, maybe a little pressure point up on the wrist, a little extra pressure on your bandage there might be enough to tamp it down. So I saw this as on the case present on one of the test questions was it had to do about a snow blower, and the blade got stuck. And what do? Do you reach in there to turn the blade? I'm like, where is this coming from? So we have the maintenance guys up there, the guys who drive the cat, the lifties that are running the lift. Yeah, there's moving parts up there. There's a potential for someone to lose a hand.
I actually had a police officer lose his trigger finger to that exact mechanism of injury, and was there when we had to get him down to surgery for that. So it does happen in this area.
Yeah, and you know, a lot of the married guys that use the Teflon or the silicone wedding band now is because a lot of guys you know, had problems with getting their wedding ring caught up on objects, and they were losing that ring finger. So lower extremities, we probably run through these real fast. It's the same thing. You might not be able to perform a complete neural exam because the patient has got a boot on. And like we've said before, we might be deciding that we're going to use that boot as a splint. But if we're going to remove the boot and we're going to assess the injury, we want to move the toes up, a dorsiflex, or move the toes down, gas pedal, plantar flex. Where the technician is palpating right there, the pedal pulse. We want to feel for that. And like in the picture we saw in the front that somebody had the sharp eyes, you take a pen and you mark it with an X. That way somebody else, it's one, that they know that you've done it, and two, it's easier for them to find the next time. So when you're going to do a reassessment and I reach for that X and I don't feel nothing, well, somebody had marked it once before. That meant there was a pulse there, now there isn't. So that lets me know there's something bad going on, right? Okay. Pelvis fractures. Takes a lot of force in a young person to fracture a pelvis, okay? We're talking falls from 20 feet or higher for an adult that's a good, healthy age. Do we have that potential on our hill?
Yeah, so I think I would argue that one guy, if he had slid a little further down and nailed his pelvis, that could have been hit enough energy there.
Yeah, yeah. But I think the point I'm trying to make is we have jumps and features in the park that take people to great heights and great falls. And I think people miss that, is that when you go off a jump, it might be 4 feet in the front of that jump, but your landing is, you know, in excess of 10, 15, 20 feet on the other side. So just make sure that, again, we go back to that whole mechanism of injury. Can we, you know, is it a high-speed collision? Did he wrap themselves around a tree? Did they wrap themselves around a Jones valve or the slow bowling machine or one of the tower poles? They're padded, but, you know, you're balling down that hill and you wrap a pole, you know, that 4 inches of cold plastic padding that's been sitting up there for freaking 6 months in a shack and now is wrapped around an iron pole, cemented in, ain't going to provide much of other than, you know, you're not going to have that big of a birthmark on your face when you hit it. So just remember that you have, you know, your bladder and the blood vessels that are protected inside that pelvis area. So you have that. So you want to make sure that you assess for internal bleeding and prepare for the patient to go into a shock, hypovolemic shock. Splinting hip fractures and pelvic fractures is kind of difficult. And do we have anything as far as any new splints for that?
No, I mean, right now we'd probably be left to use a sheet or a blanket, but I do want to get a pelvic splint. I think it'd be worth having at the top shacks just in case. They're not that expensive.
So when dinosaurs roamed the earth and Patty and I were on the streets, they had these things called mass pants, trauma pants, and they were inflatable, and those were great for femur fractures and pelvic and hip fractures, where you threw them into these pants and then you can inflate them. They were a great splint.
Hey, Tony,
Yes.
I think one thing to mention about possible hip fractures or some pelvic instabilities is using a scoop stretcher and ordering one from the top, because it's going to be pretty hard to move these people. They're in a lot of pain. And so I just wanted to put that out there, that's a good tool to use with these kind of patients, is the scoop.
Yeah, that voice of old sage wisdom. It sounds like almost like a Martha.
No.
Yeah, she's absolutely right. They still carry scoop stretchers, and that's the one thing about them is that you break it apart, and then you can bring it on both sides of your patient, and you basically just scoop them up into it. So we're not having to do a log roll on a hard flat to move the individual, and it's less painful for them. And then there's a technique using blankets and in a crisscrossing manner to be able to stabilize the pelvic fractures. Hip fractures, hip dislocations. They usually present. There's a lot of pain. Again, it's a large joint. It's attached to the largest bone, so you have a lot of risk for damage to nerve and blood vessels in that area. And of course, it's one of the most common fractures that we see in our older geriatric population, which on our hill, we actually have a pretty big group of people that are in our 60s and older that enjoy skiing up there. Hip fractures, very, very painful. They don't want to move anything. So be as gentle as you can. Very slight movements. If you're going to do a movement, it's, prepare for everything that you're going to do. Prepare your patient. And you want to plan out your movements because you don't want to make more than one or two. And you always want to check, before and after your movements, the CMS.
I put in the chat a picture of the pelvic splint I'm looking at. Pretty basic, just kind of wraps around and then uses a kind of a pulley mechanism in the center to apply traction.
So the dislocation, so next slide will probably mention how do you know it's dislocated. So you're going to get, usually it's shortened and it's rotated. So just like this person's laying in the snow, most times you don't see their knee bent like that. It's usually, you look and already you notice that the legs are usually side by side together. But the first thing you notice is like the legs turned outward and it's obviously shorter than the other leg. And so, go ahead. Mechanisms of injury. again, is usually a twisting, a landing and twisting motion. Leg kind of gets, or you're doing some extreme split. But it always goes back to that rotation and shortening effect. Okay. You can get a fracture of the femoral head with the dislocation. The sciatic nerve runs in that area. There's a notch back there where that nerve runs through. So again, another reason why you want to be very careful about trying to pop this back into place is because you can pinch that nerve in there. Same thing with the large vessels that are running through there. So
If their hips displaced, they're not going to be able to move that leg, right? Like,
oh no, you can move it, because the one thing you'll notice is, and like when Martha was saying about the scoop stretcher, is you're going to see a drop in their ass. I mean, when they talk about that tenting, if you expose that area, you'll see a drop in their butt from where that popped out. So just like what we've talked about before, you're going to try and immobilize them in place. So in this case, using the scoop stretcher as a way to securing them to that and immobilizing them, making them comfortable, which might be just shoving a pillow or some padding underneath the leg and the knee, and trying and supporting it as best as possible.
So I have.
but they.
Oh, go ahead.
Go ahead, Pat.
So would you call this a critical patient, or would you call this kind of patient, that they can go by car? Anyone want to volunteer for that one?
I'm going to say ambulance.
Why?
I'd say critical.
Put
Yeah,
some
you got
pain on 'em.
nerves and
You're bleeding.
you got
Pain meds.
arteries that run through there, and
So any injury that can cause or has the potential to have long-term permanent disability is an emergency that needs to go by ground transport via ambulance. So yeah, someone that's got a hip dislocated, an elbow dislocation. If it's somebody that it's the first time they've ever dislocated their shoulder, probably not as severe as the hip, but we want, it's person with a hip fracture or a hip injury dislocation, they're not going to argue with you, because the one thing we're going to offer them when the ALS unit arrives is when they get here, they're going to start an IV and they're going to be able to give you some pain medication. If you
and
get in the
just to
back
go.
of your F-150 in the back, you're not getting any of that. So, yeah, this is somebody we definitely want as a critical patient that needs to be transported.
And just to clarify my question I had earlier, as far as moving, they physically won't be able to move that leg. So if there's you get on scene, if they're not able to move their leg, if it's immobilized, that's a sign of a displaced hip, correct?
Yeah.
Okay.
And
symptom.
Everyone that I've ever ran on that's had a dislocated hip, they told me it was dislocated. They know it's out, because one of the pain in the groin area, the fact that they don't want to move, they don't want you to touch that leg, and a lot of times we tell them before the pain, we're going to start an IV on you, we're going to give you some pain medication, and then we're going to move you. Sometimes they're in an area or a position that doesn't take place, and we let them know it's going to hurt. We're going to do our best to support, assign somebody to that leg. You're going to cradle underneath their ass where the head of the femur, the femur head's at, and support at the knee. And then in conjunction with wherever we're moving that patient, you're going to move them in that way and be supportive. Okay. we're talking here about it's divided into 3 sections: proximal, which is the hip, the femur head, the shaft, and then the distal femur, which is going into the ankle. So that's a mid-shaft femur fracture. Okay, and the thing with femur fractures is once you apply traction, you usually are told right away that they feel better, because some of the things that are going on with that fracture is your biggest muscles are in your thighs, and those things are spasming to be able to keep that from moving around. And then once you apply that traction, that usually releases that muscle spasm on their leg also, and they get that relief. And that's the whole purpose of the traction splint, is pulling that bone back, and securing it and helping to release some of that spasm. So again, going back to that mechanism of injury, the signs and symptoms are the same as any other fracture that you might see. Just remember the intensity of a femur fracture and the amount of damage and the risk of bleeding out is very real. Next. We talked about all of that. So always make sure you do your CMS when you're evaluating the leg fractures, and we're checking that pedal pulse. Next. Knee injuries. So again, that goes back to mechanisms of injury. We know that it's going to be ligaments that are involved. There's the instability that we might have. The best way to assess it is being able to get the pants off or see it. But you're not orthopedics. Just a small tear can cause a lot of pain in some people, depending on where it's at. The more swelling that you see initially in the field would probably be a better indicator of how much damage there is. So, look for swelling, the point tenderness, some bruising. Again, the tearing of the ligaments in there causes a lot of blood, a lot of that synovial fluid to be released in there. If you've ever had your knee drained from doing that, it's one of the few times I passed out on a table. So it's not something that you want to have to go through. Again, how do we treat this? Everybody go to sleep.
Splint ice transport.
Yep.
Boom.
CMS, before and after.
Okay. And again, with the knee injuries, splinting that, it might be nothing more than, splinting it, keeping it straight, splinting it, some padding in the back, position of comfort. So you might have to get creative in how you build your splint. So you might have to build your splint where the knee's already flexed because they can't straighten it out. They don't want to straighten it out. So next. Go ahead. We've covered all this. Going back again to our anatomy. Just be familiar with this. Next. Again, those inside bands, those are the ones that you're usually going to see to get operated on. The meniscus usually is just they go in there and they clean that up. So next. And you're not going to know, you know, what exactly is, you know, is it a meniscus tear? Is it you know, what exactly I did to my knee? That's something that they're going to have an MRI on to get a true diagnosis. We just want to know. We just know that any knee injury is going to can be painful on a scale of 1 to 1 to 10, and we're going to treat them all the same. We're going to splint them in a position of comfort. Just know that the kneecap, the patella there can become displaced, and that whole patellar ligament can tear and pop out. So again, until we get the proper training, we're not going to pop it back into place. Although it is one of the easier ones to pop in. And I think that's true with any dislocation. Once you dislocate something, it's because you loosen up the ligaments around it. It has the potential to keep dislocating. So again, in your patient assessment, that's one of the things you can ask them. Have you ever had your knee or shoulder, has it ever popped out before? And a lot of times they're going to tell you. Again, we're going to treat this the same way. We're going to splint it, okay? And recognize that it's a true emergency, and we're going to get him down the hill. Pain management. He needs ortho. Next. More of the same. Next. Tendon and ligament ruptures. They usually hurt a pop. You've got that little tenting or a gap, unable to straighten the affected leg at the knee. Again, like an Achilles tendon, you get that foot drop. Pain at the affected area. How are we going to treat this? Splint it. Tib fibs. Usually if you break the tibia, you're breaking the fibula. Splinting those are pretty easy when you start from the knee down to the heel and up the foot. The classic splint that you see a lot. Those are usually the easiest ones to splint. Just remember that the force it takes to break both of those bones. So if you've broken one, suspect that the other one is broken. Same way with the humerus and the ulna. If you break one, you're possibly going to break the other. But it's the same effect. We're just going to splint. Recognize your MOI, I'm sorry. Tib fracture right above the ankle bone there. What kind of fracture is this?
Open.
Open. Okay. So what's the other consideration we have to take into is?
Infection, bleeding.
Control the bleeding. Okay, next. This is the one I was talking about, the skier boot. Because of the way the boot is, that flexing forward, you get that snap above the ankle. So also you can get the spiral fractures because of the way we fall. And we do that helicopter. One ski's going one way, and you start helicoptering the other. If you're depending on your bindings, what they're set at, you don't pop out. So learning how to fall is always a good thing. So the compartment syndrome is a condition in which the muscle swells but is constricted by the connective tissue around it, cuts off the blood supply to the muscle. Again, this goes back to when I was talking about the femur fractures too. You get that muscle wanting to swell and spasm on you. A lot of blood loss there, so you want to make sure that we make sure we're doing a good assessment and transporting. What can we fix on the hill?
Not much.
Exactly. So just remember, our job is to stabilize somebody and move them from point A, which is, to me, point A is the hill, to point B, which is far, to point C, which is ground transport, ambulance, to final destination is the ER. So we're conductors on a train, and we're just trying to get everybody going in the same direction to the same destination. Ankle
Their
injury,
inability to move.
And again, not just skiing or snowboarding, but once you kick off your boards and your sticks, and you start walking around in ski boots and snow boots, I was surprised in the design of the new restaurant area. There's a lot of steps going up and down, which makes it easy for people to freaking twist an ankle, slip on a stairway. So just prepared for, again, what was the mechanism of injury, and assess the patient accordingly. Next. 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 Ugh, I don't like that one. So we probably all go all the way to the end, Patty. So I think after this, like I said, it's just a repeating what we've been going over all night long is, there you go, types of splints. So we have soft, rigid, traction, improvised. So if we can move through these. So the soft splints are your sling, swath, and swath, right? So you should always in your fanny pack or your backpack have at least 2, if not 3 cravats in there. So you can immobilize the upper extremities such as clavicles or shoulders. Or if they've got a mild, if they've got any kind of arm injury, once you splint it with a rigid splint, you're going to want to be able to support it. Are we getting any air splints?
No, we don't have any air splints. I do want to get a couple of vacuum backboard splints, full body. So in combination with a scoop stretcher, you can really do a lot with a vacuum backboard. But we don't have any arm or leg vacuum splints.
Yeah. Again, in improvising with the blanket rolls is always an option for us. So the rigid splints, we have the SAM splints. Are we still carrying cardboard splints?
Got cardboard leg splints, and then we have that Scotch cast, which you just get wet and then it starts to set. You just kind of pre-wrap the skin, put that underneath, conform it to the position of comfort, wrap over, and it'll start to do a hardening, create a splint that way.
And we're using those until they're gone, right?
No, I have those coming in. I like using them. We're not going to be doing any of that, the orthoglass where you're laying strips of fiberglass down
Yeah.
and using that kind of putty stuff. That was too much, but the Scotch Cast is pretty straightforward. It's a solid product that's easy to use. I think we can all learn to use it effectively.
And again, we're all gonna have to, at one point in time, get into FAR and get our hands. This was the old quick splint that we used from Millennial. So the traction splint, like he had said, we've got the newer ones.
That's it right there.
Right? Yeah, that's it right there. And you can see it's pretty basic. It's almost, if you have extendable ski poles, that's basically what it is with two straps. So
I mean, we'll keep the Sagers up there as well. Perfect example, we had the bilateral femur fracture. That's 2 Slishmans being used. Get another guy going down. We're going to need to employ the Sager. There is also a Kendrick down in the first aid room as well.
So, and again, these are things that you need to get your hands on to be able to use them. If you could go back, please, Patty. The big thing with the traction splint is the required force that you need when you're doing this. So you don't need to put your foot in the person's groin and grab it with both hands and pull back. It's more. I know they talk about pounds of force, but you're using enough force to pull on the fractured femur area to where the patient gets relief. Okay, so you don't think about, I got to crank down until I get 15 pounds of force. It's I need to go until the patient's got some relief, and they'll let you know. Okay. So principles of splinting is just immobilizing that area of injury. It should be common sense. You want to make sure we control the bleeding. You want to be careful to align the injury. You want to align it as best as possible, and also as far as what the patient's going to tolerate. If you can, with a femur fracture, a lot of times you want to marry those two up. Helps keep them stabilized. Same way with the arm, splitting it to the chest, it gives it more stabilization, especially when you're doing the transport in a toboggan. We talked about this at length, the CMS before and after. You want to document, mark. Make sure that you properly size the splint. So when you're building the splint, you're using the actual measurements of the person that you're applying it to. So build your splint, make sure you're building it next to the extremity that you're going to build it for. Put padding in areas that you need to. And nothing I can add. We talked about this at length. So don't force exposed bone fragments of an open fracture back in. Don't try and manipulate a fracture back to a position if it doesn't want to go. I think you keep going, Patty. The use of cold packs in conjunction with your splint. Remember, you don't want to put it on bare skin. So, you know, once you put your bandaging in place to hold your splint there, you want to make sure that you're able to put some ice in between there. And I think we go through all this too. It's all the same. Okay.
Just especially with clavicle fractures, you don't want to put that sling over the injured clavicle, obviously.
Right. So a pillow splint. This was one of the ones I loved using on the streets. Is we were at someone's house and I wanted to make a splint. Is I would just grab their pillow and wrap their ankle in it, and you know, it was great because it's comfortable. It's fast and easy. I think you can go the other way, Patty. There you go. You probably just go right to the end. So we've already kind of talked about this in the beginning. It's, you know, the injured skier that we saw in the very beginning. You notice his left shoulder seems lower than the right one, and one of his buddies standing by says, "Wow, that was awesome." He's complaining also that his left knee hurts and feels funny. So what don't we want to do with this patient?
Don't overlook one injury for another.
Great. That's exactly what that's all I cared about this whole thing was, hey, his chief complaint might have been my knee hurts, but you, by looking and assessing him, notice that his left shoulder seems lower than the right one. So when you're assessing him, what's one of the things you want to ask?
Have you ever dislocated your shoulder?
Right. Is that normal? Hey, your left shoulder looks a little lower than the right. Is that normal for you? Yeah, I've dislocated this thing so many times, and you know, I don't feel like getting the surgery for it, so I kind of look kind of goofy. So don't get tunnel vision over one thing and overlook another, but consider them both, and consider what the mechanism is, the MOI versus what's normal. Okay. All right, next. And then how are we going to treat that?
Splint and go.
Splint.
So you find a gross deformity of the knee with the tibia shift laterally from under the femur. No other injuries, and you call base and request EMS transport. So you come across this skier in the snow. You've made your initial assessment. What are you going to call for? What are you going to tell dispatch you need?
Splints, toboggan.
So I need a toboggan with a trauma pack and a splint. Advise we're going to need ground transport. If you need more hands other than the person that's coming down with a toboggan, okay? So again, go back, start formulating your plan. You know, what resources do I need? Do I have the resources on hand already, or do I need more resources? Start formulating all that stuff inside your head, because you're the one that we're dependent on to get the information to, so we know what we need. And then, you know, if you're first on scene, you've done the patient assessment, you've initiated a patient treatment plan, it's your job to transfer all that information over to who you're handing that person off to. And who can you hand that person off to? Who can you hand your patient off to?
And your
Same
own
level of
thing.
care or higher level of
Very
care?
good. All right. Any- He's able to walk again. You healed him. Thank you.
Excellent. Okay.
So the skills activity, we're not going to be able to do that because of
Yes.
you got nobody to practice on. So just read over it. YouTube is a great tool. YouTube University, we call it at work, or the guys we call it, because you can go on there and just about find anything. So with splinting, go on there and look up how to, certain splints and how to do them. Is there any questions from anybody? Anything that I missed or I wasn't clear on? Did we go over our time there, Patty?
It's 8:50, which is really good. Make sure that everyone signs in, please, before you leave. You've signed in once. I want you to sign in twice. And if you have anything for Rizzo, please speak up now or ever hold your peace.
Yeah, I do actually have just kind of a general question. So do you tend to see certain types of injuries based on the condition? So if it's super hard packed, people are going faster, they fall over, the snow's less forgiving, maybe they get more upper extremity injuries, broken wrists and things. And then softer snow, do they tend to get more lower injury because of the wandering skis? And
yeah, that's good. That's a great question. Good point. Yeah. So the Sherwood has a nickname. We call it the white strip of death, because they when they start blowing snow up there, it's usually cold, wet, and icy, and it gets hard packed really fast. And like you said, and you get you get those hard packed icy conditions where you have more of a tendency to hit outstretched and fall, and you don't have the ability to absorb that impact. So you see different injuries compared to a powder day. Like you said, you're skiing above your ankles. You're not keeping track of your skis and losing position that way. Also too, on depending on how they've got the terrain park running that day, you might see an increase of certain injuries because of the way guys are coming off the jumps. 1 o'clock is usually the waning time. It's right after lunch. People have had a few more trips into the bar. They're a little bit more tired. They're using so they're not making good turns. They're lazy on their body mechanics. So you really start to see your injuries start showing up usually after 1 o'clock. So between 1 and 4 o'clock is when you really start to see stuff.
Okay, thanks.
Anything else? Anyone?
Yeah, I had a question for Mike. He said we're looking at as far as the shoulder dislocations. I've heard it both ways. I know our guidelines are we can't put it back because, as he said, because of nerve damage and all that stuff. But I've also heard, if we had our ER docs here, maybe they could give us some input, that the longer you wait, the worse it gets. So putting it back in sooner is better. So how do we balance that?
Exactly. So that's kind of where I came from in Colorado, the ER doc that runs the medical program there, he's kind of spearheaded an approach to work with a waiver through the state to track and treat shoulder injuries, there's a whole protocol in how you are taught to diagnose a shoulder. And pretty much if you can't discern if it is an anterior dislocation specifically, you can't treat it. So you have to have all of that evidence has to line up, mechanism of injury, where the pain is, range of motion tests. And then if you do assume or identify as an anterior dislocation, you have 2 attempts to try to do the reduction. And if those 2 fail, then it's a no-go.
Yeah. That,
After that, there's a whole process of follow-up. There's also 2 signatures of a release of liability from the patient and a release to for contact later to follow up with their docs, whoever they go to see, and themselves to make sure that they followed up with professional medical doctor to get it assessed for neurological and circulatory like any other compromises that may have resulted from the reduction.
okay.
So yeah, there's a lot of processes involved. Again, that's not going to be something that's just going to happen next week. It's going to be a season-long process, and then even still, it's probably going to be limited to EMTs or hire from the outside. So if you're a paramedic, you're pretty much operating at EMT here on the paid staff only, and for those who are only trained by the doctor, on a yearly basis. So a
So
very
if we,
limited scope on who can use that technique.
but if we have somebody up there that can do it, that's, like I said, that's going to help that time factor a lot.
Yeah, and the argument that they're forcing in Colorado is that some of these mountains are an hour from definitive care.
Right.
So within that whole hour, or if they want to go by ambulance and it's snowing, it takes this longer. My argument that I want to push is, sure, we're only 45 minutes from Centennial, but when you go to the ER in Centennial with a shoulder dislocation and there's 5 heart attacks ahead of you, there's another hour, 2 hours that you're just waiting in the waiting room with a shoulder dislocation that seizes up. And now you're going to surgery because we
nerve
could
damage.
have reduced it and we didn't have a chance. So that's the argument.
It all goes back to what's your level of training and then the local protocols in it. And unfortunately, because we don't operate under local protocols, we operate under NSP and the OEC protocols. They don't teach it, so that means you can't do it.
Right. I understand.
So,
but it's that balance where, I mean, shoulders and fingers and stuff where it's an easy reduction. Well, not easy, but like as long as you know what you're doing, you can do the reduction and save that nerve damage on a trip down. So
yeah,
it's that balance.
I mean, that's kind of that fine line where somebody's like, yeah, I think my shoulder dislocated, but I think it's back in now. They somehow along the way just relaxed enough, the musculature relaxed enough, and it allowed it to come back into the glenoid, the glenoid socket. So it happens on its own sometimes, and maybe you can coach them. Again, you have to have a very fine line on what you're allowed to do there. Just you want to advise them to not do what they see in the movies. Do not try to hit it into the socket,
Yes.
stuff like that. Like you want to avoid damage if at all possible. But
Yep.
Whatever makes them feel more comfortable might eventually end up having it pop back in. I don't know.
Yeah.
But what we see is usually when you try to pop, let's say they popped it back in or it goes back in. Oh, can I go boarding now? Can I go back on the hill? Oh, wow, I feel really good.
Right.
And then guess what? It
They're
doesn't.
not so good.
And that's part of that, like I said earlier, with even just the disposition on a normal incident. We splint it's just a broken finger or whatever. We splint it up, they're good to go. They go back out. We just have to document that disposition, what we advised them to do and what they said that they were going to do. They come back in and blame us for letting them go back out. It's like, no, listen, we have it all written down right here. You signed it. It's all about documentation. Very important part of our job.
Anything else?
You
Good?
talk about I was just going to ask about, like talking about higher levels of training and sort of going from the scope of practice, staying within the scope of practice. Is there a clear delineation as to when, if there is a higher scope of training, but they're just say there is an OEC tech to step out of one role into the other? Is there some clear cut way of doing that? Or is that something that they sort of have to go through you to figure out, or how does that work?
Pretty much the way Dr. Patel, I mentioned that to him, and yeah, it's just not a good idea to, I worked for the Gov. We would go on annual leave for the hour that we wanted to help somebody out outside of our scope. That's a very dangerous thing. We have a delineation of what we can do and can't do on the mountain, and anything outside of that, we just need to activate 911 and get them down to the ambulance and transfer care as soon as possible.
So like for me, when I was with the fire department and like with Patty currently, we work under the Clark County Health District protocols down in the valley. So, I could do IVs. There was medications I could push. I was a paramedic, so, I was able to intubate. On the hill, I'm a volunteer. I can't do any of those things. Now, have I done that under certain circumstances? Yes. But that was because it was in a benefit to the patient at the time, and I was willing to take the risk that I was doing something that was on the side of the patient's benefit. That's where it gets cut off. Okay, if as a volunteer patroller, you operate under the OEC of the National Ski Patrol, and that's where your protection's at. So if you do anything above or beyond that scope of OEC and NSP, then you're hanging yourself out to a liability, and the resort won't cover you or won't protect you either. So
Right, but we were just talking about like how some EMTs or paramedics, sorry, might be trained in reduction of like, so that's stepping again outside the OEC, but those are only on staff, I'm assuming then?
Right, yeah, so under
That's the delineation is on staff.
we've established medical direction with protocols that the doctor is signing off on. So there are some things in that protocol that are going to be outside of OEC. So as a volunteer, you're limited to OEC. Paid staff with an EMT or above or underneath the protocols of the paid staff, then you have those, like we're getting epinephrine. And that's something we want to have on the mountain. Again, that's going to be for the paid staff.
That makes sense.
Right.
So it's essentially whether or not you're volunteer versus paid staff as to how much further within your scope you can go. That
Right.
makes a lot of sense. Okay.
Yeah, it's just the liability with the difference between NSP and what our medical director is
For
given.
sure. Yeah, that makes sense.
And
Thank
we
you.
have tried, we have talked about in the past of switching over to coverage under Clark County Health District protocols, but then you need a medical director. And it also, you lose the protection of NSP for liability on the Hill. So it's there's some good and not so good about it. So the way we have it set up now is, the paid operates at a little bit higher level than volunteer. But the one thing I always push is that if you do what you're trained, you stay within your training, and then you do everything as a benefit to the patient. So if sometimes you step out of that black and white line of doing what you've been trained to do, like me, I'm able to kind of step out a little bit of that line because I've been trained up to a certain level, but at the same time, I'm not at that level when I'm up on the hill.
So at that point, it's your choice to step out and take the liability to yourself at that, because
Yeah,
you know
and-
the town's not going to hold it.
And
Yeah.
it's
Yeah.
always worked in my favor that whenever I've done something, I don't do it to the benefit of anybody else other than
The
it's
patient.
to the patient's benefit. And then I use my documentation of, well, why did you do that? The protocols on for you are this. Why did you do that? And then I'm able
X, Y, Z.
yeah,
I mean,
Yeah.
yeah, if you can cite that there's a life threat and you had the ability to intervene, benefit of the patient, you have to catch that up in documentation at some point. It's going to need a lot of documentation to make sure that nothing comes back.
Right.
Yeah.
I think we're used to that in this field in some ways, but I just wanted to make sure that I understood where the delineation fell and as to why it was one way or the other. So thank you for clearing that.
Yeah. Thanks.
and the great thing too about being on the hill is that there's something there that you don't are is not that to your level, but then you call for help. You get somebody else on scene with you. There's we've got a great group of individuals that have, a wide spread of abilities and expertise. So for you guys that have never, touched a patient before, don't hesitate to call for another patroller. That's one of those things that in the morning when Mike's having muster, and he's putting out assignments, know who you're with on the hill. Know I've got, so and so, know that you got Patty, that's a medic. She's been, involved. She's over on Sherwood. That if I get something that I can't handle, hey, I can request for help, and I can expect to see her.